Welcome to the Reimagine Patient Engagement Podcast. This podcast aims to answer the changing dynamics in patient engagement. What role does technology play in the space, and what are the key initiatives and metrics each individual in the ecosystem expects? Let's get started.
So hello, everyone, and welcome to Reimagine Health, a podcast that focuses on population health. Today, I'm really pleased to introduce Rachel Linonis, who serves as the Director of Digital Solutions for the UCLA Semel Institute's Nathanson Family Resilience Center and UCLA's Division of Population Behavioral Health. Her mission is to digitize a public health approach to behavioral health treatments, ensuring that a care system's digital ecosystem supports patient screening and access to customized treatments, monitoring, and preventative resources. She has extensive experience operationalizing integrated behavioral health care within psych and non-psych service lines, including primary care and oncology, and she also supports telehealth, video and remote monitoring, and prevention-based education innovations across the health system and community settings. Prior to her appointment to UCLA in January of 2012, she was a software developer for the United States Census Bureau and a GIS specialist for Aerospace Corporation. Rachel holds a bachelor's degree in math and geography and a master's degree in management information systems and is a certified project management professional. So all I could say, Rachel, is wow, great, and welcome to Reimagine Health. And we're, like I said, very excited. Behavioral health is really near and dear to my heart. And I'd love you to kind of talk to our viewers about how you became really involved in behavioral health and what really made you fall in love with it.
Sure. So yes, I'm so excited to be here. And, you know, it's interesting. My background, I didn't study healthcare. I didn't go to school for it. I came from the math side and I got into software development. And I think there was a part of, you know, in my early 20s where I wasn't quite sure what I wanted to do with my career. I was kind of doing this government thing. I had to get a secret clearance. I never really knew what my work was doing. Like I would have to work on a project and then it would float up somewhere, you know, because I didn't have the right clearance levels. And then one day I had moved out to California at this point and I had gotten a call to join a small team that exists within UCLA, but specifically the Semel Institute. And it's worth just describing the organization piece here is that we do health system work, but we're also in research and education. So I've been lucky where I got to see both health system work, but also sort of in the community. And so when I started back in 2012, something that really struck me was one, that's when everyone was moving to EHRs. I had just come in, so I saw sort of this whole digital transformation happening at that scale, which was really fun, really interesting.
I can imagine.
Yeah, so if that was very interesting. But, you know, this group that I work with, I mean, I'm really standing on the shoulders of giants here. There is, you know, the researchers and the clinicians that I work for, they are innovative in their own field of psychiatry. So they recognize that psychiatry in and of itself, regardless of the digital, needs to innovate and just take a public health approach to looking at behavioral health. I think personally, you know, I've been through personal experiences. I am a cancer survivor. I've had, you know, medical sort of issues, but then also coupled with mental health issues, which obviously is going to happen if you go through anything traumatic. I appreciate clinicians that look less at the individual. I mean, obviously the individual is important, but also look at the broader picture, what's going on in their family, what's going on in their, you know, socioeconomic status. I mean, all these things I think are so important. And the clinicians that I work for, you know, they're really spearheading changing that model. And I come in to help support them from a digital perspective because, you know, what I've learned is that the EHR in the health system doesn't really support that work, if that makes sense. So that's kind of where I come in. And so I've been passionate about it because since I've started, I mean, I've seen mental health, you know, it's getting worse in our country. I think the current model is not really working, and I think it does need to change. And that's probably why I'm so passionate about this work and why I want to promote not just this type of work, but also promote the clinicians and the researchers and the educators in this space too.
Right, exactly. And if you look at COVID and how COVID has affected really mental health, I mean, it's just, I think, exploded. And I think we've now said, this is something that really needs to be looked at. And I could say working for years and years and years around mental health, it was something that was way over here, right? And it wasn't part of, the diabetes or the blood sugar or the blood pressure. It was always something that was out there, but you never could reach it, or you couldn't find the right people to really treat it. And I think to some extent that goes on today because there's just not enough mental health professionals to really, really help. So looking at that, that whole area, so some of the biggest challenges that you find envisioning and implementing digital solutions in a health system. I've come from a health system. I know that a lot of us have dragged we've dragged our feet because it's difficult. It's the workflow, it's the patient load, it's everything. And then our own sense of stress and anxiety. Like even today, will the system work? When we're on the podcast, is it going to work? So when you have one person after another and you have people waiting in your lobby, it's really like the whole idea is really kind of like scary. And it's not that people don't want to do it. It's just that it's just difficult.
I think what's interesting about the health system is, and I'm going backwards in time to 2012. Like I remember when the EHR was first set up at UCLA. And you have an entire workforce that is around the EHR. And it's not just like hundreds of employees. It can be like thousands of employees. Sure. And from a software development perspective, when I think of the EHR, I think of a system that was set up to do fee-for-service things in a fee-for-service world. Like it's not evil, it's not malicious, but that's why it was set up. Right. And now we're kind of realizing, well, maybe the fee-for-service model, like just where I sit in behavioral health, the fee-for-service model doesn't really work well for behavioral health. So in order to, in a lot of ways, like I come from this middle management perspective where you have to work on the ground and partner with IT people. They may not be hearing from their boss that, hey, population health, this is what you need to do, or this is the way you need to think about healthcare. I kind of looked at that. That's my job. That's my job to get really clear with that goal and explain to the teams that I'm trying to partner with, like, hey, this is why we should do things this way. And it requires getting buy-in because ultimately, anytime you're implementing a digital solution, you're actually changing how people work. And people don't like to be told what to do, and that's fine. I'm not here to say you need to do this, you need to do that. And ultimately, and I think we'll get into this later, it does become a leadership issue, right? Like someone has to come in and say, hey, this is the way we're going to do things. Yeah. And then there's also just the financial piece. Like, I think the strategy needs to come before the technology. Like the strategy should be set in stone and the technology comes in to support it. But often what I see is like the technology comes in these small pilots, but there's no large scale systematic strategy that says, hey, we're moving all the way to population health. It's hard to be hybrid. It's hard to scale a solution in kind of both worlds. Like it's really important to pick a lane. And again, there's no us versus them mentality here. It's really just, I'm just thinking of an example right now with some of the psychiatry colleagues where they were ready to do telehealth. Their patients were ready to do telehealth. Their insurance wasn't reimbursing them. Right. So, and then finally when COVID happened, they were able to do telehealth the way that they wanted to, but we had to wait for insurance to actually reimburse them. So it's all these dependencies that make it very complicated.
It's not just one thing, and it's the whole payer system. It's everything. It's complicated. And then, too, if you look at the EMRs, they're not really intuitive, really. And it's, like I've been doing a lot of work around social determinants of health, and sometimes they're there, but they're buried, and you can't grab them. So there's nothing, it's not like bite-sized chunks of information that would come to the provider to alert them, and you're looking in a lot of different places. So I think from a whole system perspective and a workflow perspective, it's really, really a challenge, and it's difficult, I think, but it's just going to take baby steps and people like you that are really going to help clinicians and people like me to really kind of edge toward a better outcome. Exactly. So what do you think should change to kind of bring more agility in trying new technologies? And I think this is, it's funny, we talk about behaviors, and I work with people with diabetes all the time. And, behavior change is so difficult. It takes time, and it takes encouragement, it takes nudging, it takes commitment, and it doesn't happen overnight. And oftentimes, like systems or payers, they want behavior change to happen overnight, and we know that doesn't happen. It takes time. So when you put that on a healthcare provider too, you know, like I'm trying to change my workflow and things like that. Behavior change for us as clinicians is difficult. So you have kind of like two levels. So let's talk a little bit about that and think about, you know, what we can do or any thoughts on that you have.
I have a thought. It might be controversial, but I think one of the biggest things that we could do that I think would help a lot, and this is where it shows where my priorities are. Like, I do believe in empowering the clinician. I think so often I see the clinician like that they want to treat a patient a different way, but they're stuck with the tools that they have at their disposal. Right. I think is unfortunate. So I think one thing that could help is making sure that whoever is building the digital or tech solution is literally working close by the clinician seeing the patient. So they get to see the heartache, like you said, the EMR is not intuitive. I mean, we know it's burning out clinicians.
Right.
So I do think it's really important. I mean, I've been very lucky where we do have a team of engineers that we work with, but I also get to spend a lot of time with clinicians, so I understand their pain points. And I do believe that they know their patients. So when they're telling me what they need, they're not just telling me what I need as a clinician, but they're telling me what my patients need. Right. And I think that's such important information for someone who works in IT or someone who works in, analytics or data or even anywhere on the technical side. I think often find in these health systems, they're so large. Sometimes that gap is too big. That's where I think I find myself is I'm filling the void between IT and what the clinician and patient needs. And there needs to be a way to close that gap at scale. And I think that could really help because I think it would allow, tech people and digital people and data people to fully understand the needs of the clinician and then build something to support these workflows. Because at the end of the day, the clinician and the patient, they are the most important pieces to this equation of the health system. We really should be building tools that work for them. And they know their patients and what they need more than, I do. I'm not clinical,
Exactly. And I think a lot of it is the communication piece of it. So it's frustrating when you go to a physician and they're looking in the computer and typing into the computer. And I think that that's a piece of it because I think as a clinician, I want to look at you. I want to have that eye contact with you. I want to be able to really in my mind know what's going through your and sometimes you can't do that. And I think technology gets in the way of that. And I think the beauty of telehealth is that it's kind of less stressful on both ends, right? And you could have better eye contact and you could see that person a little bit better. But I really believe one of the biggest downsides of the technology is that lack of the eye contact, seeing somebody face to face, or being reassured. And I had an interesting experience, and a physician I was there, but actually didn't even go to the computer and sat down next to the patient and was talking to the patient. And then at the end, kind of did her work outside the room. So I thought that was really interesting. That was the first time in a long time I saw that when I was in a clinic a couple of weeks ago. So I think looking at kind of people's style and what's important to, and how does technology kind of blend with that, because today, to me, it's kind of more of an impersonal, it's more impersonal than it has been. It's not that kind of the Marcus Welby or kind of what a lot of, especially the older people are thinking healthcare should be. It's kind of disruptive to them and impede some of that conversation flow. So, I mean, any thoughts around that and how to help healthcare providers, with this whole, entering the data and trying to talk to somebody and putting the data in at the same time?
Right. Oh gosh, that's such a good question. I think about this philosophically probably way too much. And I think it goes back to, when the EHR was set up, it was set up to maximize reimbursement, right? And there's a lot of documentation the clinician has to do to maximize the reimbursement. But in a population health world, that's not as important, right? It's actually more about outcomes and how can we redesign the EHR to focus more on outcomes. But we can't do that until the payers get on board, and we can't do that, and then we have to wait for operations to get on board. Right. So I oftentimes feel like we're at an impasse, and I'm not sure what to do about that and I think that's why I'm just okay, I need to start taking leadership courses. I need to start, eventually this does need to, the advocation, it needs to come from bottom up, but also top down too, to make these changes. And I feel for the clinicians, maybe because I work with them a lot, I do agree that EHRs were better off having EHRs, and I think, we're better off moving away from paper and pencil, but I do think it adds, I read a statistic that it adds 40% more work.
Right.
To a busy day just with all the documentation that needs to be done.
Right.
And some of the documentation is not even relevant. Like the doctor would be like, I'm not going to, write that. I don't need to write that, but you have to for insurance purposes. And I think that disconnect always kind of blew my mind. Mm-hmm. That I do think that there's like a human-centered design need right now for the EHR, because it's fascinating. There's two audiences you have to make happy. You have to make the patient happy, but also the clinician. Those are two really important individuals in this sort of equation. And it's fascinating to me that, what I see in health systems, that the IT teams tend to stay very far away from both of those groups. And yet they're the ones creating the product.
Right. And to your point, I really believe that who asks the patient or the person with the disease? And I don't think we do enough of that, communicating with them about some of these issues or doing surveys around them, saying what are their needs, what was their experience, what did they feel. And I think that could play a huge role. And I think now you're seeing more of patient advocacy groups stepping up and to really having a kind of a voice in the care that they're, expecting and all that. And I think as health system and as leaders, we need to bring them into the equation a little bit more, even with accountable care. There's nothing about the patient. They're accountable for their own care. I can't be accountable for somebody who doesn't want to do their care, right? So we have to build in the accountability on all ends, not just on, the payer or the providers end too. So a lot of work in that space. But I do think that the patient's voice or that person's voice is going to be really, really more important so much now and more so even in the future as we go forward. So you talked a lot about leadership, and I know that you're in a digital health Harvard course, and is it a leadership course there? And let's talk a little bit about that.
Sure. So I recently took it. It was sort of, so it came off the heels of, we had recently just rolled out a behavioral health screening within oncology. So again, this is a project near and dear, close to my heart. I really believe that we should be tracking behavioral health outcomes, not just, we should be doing it for all disciplines, all specialties, whether it's diabetes, whether it's CHF, COPD, but also oncology just happened to be near and dear to my heart. And we rolled it out, and it was actually a great success in a lot of ways, because what's interesting about our oncology group is they actually have their own social work team. So they're able to, the patient completes a screener, and then an alert is sent to the social work team so they can intervene right away. And so that went really well. But I think what was interesting, and this is through a lot of different dependencies, but that tool has to go away and has to be replaced with the CareConnect version. Sorry, we call it CareConnect. It's an Epic version. So MyChart Epic version. And I found that really interesting, because one of the pitfalls we kept running into was the API between Epic, the EHR, and our third-party tool. So even though in some ways it was better, in other ways it was actually added more risk just because of these interoperability issues. And I remember feeling really disappointed and dejected, because finally I felt like there was something that like the clinicians wanted and needed, and it had a mechanism to not just burden the oncologist, because everything, oftentimes when you're doing behavioral health work, you're actually adding more work for the clinician. Mm-hmm. And someone like an oncologist may not be trained in behavioral health, but this is a unique circumstance where they had social work support ready to, facilitate care. And it was after that experience, and it's funny. So we're in this transition phase where we're moving from this web-based tool to within the EHR tool. It's kind of opened my eyes to the way the health system EHR works. And I felt like it was my responsibility to just learn more about that. I've been in a web-based world. I know Epic, but I'm not an expert on Epic. I just know as much as I know to interface with them. But it was almost like that situation made me want to take a step back and go, okay, what's really going on here? What's the big picture story? Because I've been very lucky. I work in psychiatry, but I've got to work across the health system, but I'm not working at an executive level. So I just wanted to not only learn from some of the best in the country. I mean, Harvard is it's like Harvard Medical School. They're just really good at what they do, but also just get to meet with other leaders in this space and, build relationships. I think hearing other people's perspectives are maybe just as valuable to me as taking some of these courses.
Sure.
Like
experience and networking. Absolutely.
Exactly. Like I got to meet CIOs from health systems. I got to meet people from startups. And it's just like everyone's kind of looking, the healthcare system to me is this giant beast. And then you get to meet all these people that have different perspectives. And I think that's why I want to join. And I've gotten a lot out of it. Dr. John Glasser runs it. I think he was the former CEO of Cerner. He's taught at the Wharton Business School. I mean,
nice.
They're just very, very knowledgeable about this industry, especially in terms of the transformation leadership skills that are needed in order to spread these digital solutions and help patients and providers. And anyway, I find it really, really interesting. And now I'm more obsessed with this field than ever. I'm like, where do I go now? How do I?
Digital technologies and digital therapeutics. I mean, that's here to stay. And I think we need to embrace it. And if you look at where we were in the past and where we are today, it's like amazing what technology can do to really help individuals. And I think we just have to, and it's going to always be a work in process, right? Because it's always going to change, and healthcare is always changing and growing and learning. But I just think how it can enable individuals around their self-care. I mean, some of the things that I see, it's amazing, just working in diabetes with like connected care and trending, and when people know that their blood sugars are going down and they get alerted and the parents get alerted at school. I mean, it's amazing and how we could really, really help people, whether it's with CHF or, like you said, cancer, whatever. I think that there's just so much hope and opportunity with digital therapeutics. But like you said, everyone has, we're all creatures of habit, and it's hard to break behaviors. But the good news is I really believe in my heart, because I experience it every time, that behaviors do change and people grow and they learn. We just have to keep giving hope and encouragement and keep having people like you that can really help to build this and kind of work with all of us to really get where we need to go today. So it's just exciting, and gosh, you're doing some great things. So any last minute thoughts that you have, Rachel, that you'd like to share? I know we're getting close to our time limit, and you're just so enthusiastic. I would just love any last minute thoughts that you have.
Sure. I mean, one thought, and I was talking a little bit about this when I was looking into the podcast, but one thing that there's a book I read recently. It's called Range. It's by David Epstein, and it talks about generalists versus specialists, right? And specialists are, they're more vertical. And when you think of healthcare, there's a lot of specialists in healthcare, and that's a good thing, right? We want people that are good at their craft. And I think that there is going to be the future of digital health we'll see more generalists. So these are people that can bridge specialists together. And oftentimes when I look at my job, I'm like, oh, I'm a generalist. So when I read that book, it was so validating for me, because I was like, I'm not really an expert in anything, but I can kind of like, oh, here is a clinician. Okay, we need to, problem solve with IT. Oh, wow. Now we have to go to branding and communications. Now there's so many interdisciplinary teams that need to come together in order to create an effective end user product. Right. And in these big, large health systems, just physically, there's no maliciousness there. It's just, it's very hard to get all these teams to work together. And
it's so tunneled. Yes.
Right. But the best end user experiences, made by digital products actually require all these different pieces to come together. So I say that because I think I've written my job description a few times, and I'm like, I feel like more and more it encompasses that. It helps fill that void, and I think the future of healthcare will see more of those individuals. At least I hope. I think that will help.
I agree, because I think primary care is key today. Definitely. And it's the connection to the specialist, but the connection back is really important. I think that piece has to be worked on a little bit today. And I think, programs like what Call AI is doing and what a lot of other independent kind of technology solutions are trying to do is how do we really build the population health to really keep that interconnectivity between the specialists, the patients, the community, and whatever, to really kind of answer those intricate needs of that person.
Exactly.
Yeah. Very, very exciting. Yeah, great work. Well, Rachel, it's been awesome talking to you, and I think our future looks bright with people like you. And gosh, it's been really, really good chatting with you. So I would just like to extend a big thank you on behalf of Reimagine Health and Call AI for participating, and it's just been really great. So thank you so much.
Thank you, Donna. Thank you for having me. And yes, everyone keep up the good work. We're doing a good fight.
I appreciate it. So thank you again.
All right.
Bye-bye.
The bigger vision of Reimagine Patient Engagement is to build a community of healthcare transformers working to improve patient outcomes. Patient engagement requires patients to be in the circle of care to ensure that care is holistic and not as a snapshot during a moment of crisis, but as a view that is ongoing, continuously enriched and deepening over an entire lifetime. So, to be part of this amazing community and contribute to the vision, reach out to us at www.connectedcarecircle.org. That's www.connectedcarecircle.org.